Now, we'll be describing about the existing strategy for malaria control in India. So, malaria control in India focuses on these parts: vector control, diagnosis, and treatment. So, in vector control, we have most important part: indoor residual sprays, insecticide treated bed nets, larva control. Regarding diagnosis, we have two parts: microscopy and rapid diagnostic test kits. And regarding treatment, the drug policy 2013 is available. So we will be describing malaria control strategies. And the most important, as I earlier mentioned, is first is case management. So it begins with case detection, that can be active or passive. So anyhow, if a case of malaria is detected, so the next step is, logical step is complete treatment of the case. Along with complete treatment, the other important parts are epidemiological surveillance, like contact of or travel history and survey of surrounding areas, entomological surveillance. And in certain areas, we also have sentinel surveillance. Now, what is sentinel surveillance? We all have studied something about sentinel surveillance in relation to HIV/AIDS. Sentinel means hidden, hidden or anonymous survey. Here, the same kind of survey is done for malaria and all the other vector-borne diseases also. Here, blood is collected from the patient with some other disease for certain other purpose. He is not informed that he is being examined for malaria. Person with any disease, if he comes to hospital, his blood is collected and examined for malaria. So there are malaria sentinel surveillance sites in certain private hospitals also. So malaria is also surveyed through sentinel surveillance sites. So next in malaria control strategies is integrated vector management. So in integrated vector management, there are three parts or three aspects: anti-larval measures, anti-adult measures, and personal protection. In anti-larval measures, the focus is on environmental control, like filling up of ditches, uh, discarding of water collections or covering of small water collections, chemical control such as use of mosquito larvicidal oil, Temifos, Paris green, Fenthion, or pyrethrum-based emulsifiable oils. We can also have biological controls in the form of larvivorous fish, then anti-adult measures like indoor residual sprays. I have already discussed about indoor residual sprays. Then there are space sprays. So space sprays are used primarily only in times of epidemic or outbreak. They are used for rapid knockdown effect on the mosquito. Pyrethroids or malathions are used in fogging or in space sprays, and they don't have residual effects. The other is genetic control, wherein the gametes of male are modified and genetic alterations are done. However, this is mostly a research topic. Then we have personal protection in the form of mosquito nets. Now we have two types. One is insecticide treated mosquito nets, and the other is the long-lasting insecticide-treated mosquito nets. Now, the problem with mosquito net is we, as a community, don't like to sleep inside mosquito nets. It has some, it has related to some psychological feelings. Uh, in addition, the mosquito nets which are used, uh, they have to be treated with insecticides, but they are effective for a certain period of time, say 6 months, and in case of long lasting, they are effective maximum for 3 years. However, community is not aware of such things. They will wash the insecticide treated mosquito nets, resulting in loss of effectiveness of the mosquito nets. However, still, if community sleeps under mosquito nets, then they can protect themselves from mosquito bites. But we know that in India, there are certain areas which have very hot and humid climate, and under such conditions, people will not like to sleep under mosquito nets. So this is mosquito nets are still less accepted, or people are not inclined to accept mosquito nets. Then we can also go for screening of the buildings, screening of the windows, doors, which can be done. But once again, screening is not effective in rural areas where the houses are open from all the sides and large open areas are available from all. So it may not be possible to screen such large areas. But in urban areas where windows are relatively small, screening is possible. We can also use repellents like mosquitocidal oils or odomus, and such repellents are available for personal protection. So after case management and vector control, the other mosquito control strategies are epidemic preparedness and early response, strengthening of the referral services, and other supportive interventions such as behavior change communication. So, in this aspect, behavior change communication can be making the community accept mosquito nets, making the community aware of and compliance to indoor residual sprays, use of larvicides or personal protective measures, so and use of available health facilities. So that is behavior change communication, changing the behavior suitably to X towards the desired direction. Then we can have public-private partnership, such as partnership with the private practitioners, partnership with construction workers to control vectors, breeding of vectors. Then intersectoral convergence, like coordination with Anganwadi centers or ICDS facilities, coordination with education department, coordination between health and agricultural sectors for reduction of vector breeding. So that is intersectoral convergence. Then we want to develop the capacity of our existing health workers and health staff through human resource development through capacity building. Then operational research means all the fundamental research or knowledge that is available, how to effectively utilize them to the control of vectors. That is called operational research, that is applied research or operational research. That is to include studies on drug resistance, insecticide susceptibility, and lastly, monitoring and evaluation through periodic reviews and field visits. So now we'll be quickly describing about National Framework for Malaria Elimination in India. This was started in 2016. So the vision is we want to eliminate malaria nationally from the entire country, and this will lead to improved quality of life, improved work production, and poverty alleviation. So this is the vision long term. Now, what is the goal of this vision? So the goals are we want zero indigenous cases in entire country by 2030. See, zero indigenous case means cases can be imported, but no locally available cases or no local transmission of cases. Next is we want to maintain the malaria free status in the area where malaria transmission has been interrupted, and we want to prevent reintroduction of malaria. Now, at present, we have classified the states. Remember, previously under modified plan of operation, we had classified the areas with subcenter as the unit. Now here we are classifying the entire states based on elimination criteria into four categories. Which are these four categories? First is category 0. Category 0 is prevention of re-establishment phase. We don't want malaria to establish again in that state. So what is the criteria for that state? Any state with zero indigenous case means no cases, no indigenous case in any state, then that state will be in category 0. That is prevention of re-establishment phase. At present, there are no states in India which are in category 0. Now, category 1, that is elimination phase. That is, if all the districts within the state have annual parasite incidence of less than 1, that is, less than 1 case per 10,000 population under surveillance, then that state will be in elimination phase. Category 2, that is pre-elimination phase. If majority of the districts within the state have API less than 1, majority of the districts with API less than 1, then in pre-elimination phase. And if majority of the districts within the state have API more than 1, then that will be under intensified control phase or category 3, where different types of strategies will have to be used as described earlier. Now friends, let us understand that the vectors causing rural malaria and urban malaria are different. Anopheles stephensi causes urban malaria, while in rural areas it is Anopheles culicifacis. And so, urban malaria scheme was launched in 1971 as it has a different set of interventions to control malaria. Now, in urban areas, we know indoor residual sprays are not very much effective. There is density of population and there is a different breeding site. Like in urban areas, we have overhead tanks, underground tanks, there are coolers, gutters, ponds. There are a lot many constructions happening in the periphery of the city. So there are so many construction sites, and we know wherever there are construction sites, there are waterlogged areas, and all such sites are potential breeding ground for malaria vector. So urban malaria scheme was launched keeping these aspects in mind, and it primarily focuses on intensive anti-larval measures followed by drug treatment. So its primarily focus is on anti-larval measures, that is chemical control of the overhead tanks or underground water tanks, use of larvicides, and use of larvivorous fish for ponds and gutters. And for construction sites, there is implementation of strict civil bylaws, which means that there are laws are enacted and strict monitoring is done to avoid waterlogging in construction sites, and the laborers they are regularly screened for uh, being carriers of malaria parasite. Uh, our next disease is filariasis. So, elimination of lymphatic filariasis. Now, filariasis is endemic in 250 districts of the country and nearly 20 states and union territories. It affects, or it is a potential threat to nearly 600 million people, which means 60 crores, or half of the country's population, is exposed to the risk of the infection. Now, National Filaria Control Program was launched in 1955. 53 was for malaria, remember. Now, filaria is an important public health problem and it is magnitude is only next to malaria. So, revised filaria control strategy. So, our National Health Policy 2002 aims to eliminate lymphatic filariasis by 2050, 15, sorry. So, what are the revised strategy for filaria control? So, first thing is to prevent the disease, and second thing is to case management. So, for prevention of disease, we have annual mass drug administration. So, annual MDA, mass drug administration, is done with single dose of DEC, diethylcarbamazine citrate, which is continued every yearly for 5 years in a given area. Only it is not given to children below 2 years, pregnant women, and any seriously ill persons. Otherwise, entire population is given single dose of DEC. Now it is also coupled with albendazole. So albendazole and DEC are together given during annual mass drug administration round. Next is case management. So we can't do much in lymphedema cases. So what is to be done is home-based management of lymphedema cases. The other thing that filariasis does is hydrocele. So hydrocele surgeries are being scaled up in CHCs, district hospitals and medical college hospitals. So what are the criteria for lymphatic filariasis elimination? So lymphatic filariasis ceases to be a public health problem when the number of microfilaria carriers is less than 1% in the endemic population. The other is children born after initiation of elimination of lymphatic filariasis are free from circulating antigenemia. There is no circulating antigen, microfilaria antigen found in the blood of children. So absence of antigenemia among children is considered as evidence for absence of transmission and new infection. Now regarding morbidity management of filariasis and its disability. So home-based morbidity management of lymphedema cases and hydrocele operations are being focused upon. So a line listing is done at district level. Means line listing means just a listing of all the patients with lymphedema file or hydrocele, and the list contains their names, contact numbers, contact details, addresses, and some basic demographic characteristic. So this is called line listing. So line listing of lymphedema and hydrocele cases. The officials or health workers will visit the persons having filariasis. They will demonstrate the foot care, train them on simple foot care, foot hygiene, and motivate them for self practice. In addition, they will motivate the persons having hydrocele for hydrocele surgeries at CHCs or district hospitals. After completing lymphatic filariasis, we will go through dengue. Now, dengue is predominantly an urban disease in contrast to malaria, which predominantly happens in rural Indias. Now, there was an outbreak of dengue in 96 in Delhi. Since then, many focal outbreaks have been reported from different areas of the country, mainly urban areas. Now, dengue control is also integrated with National Vector-Borne Disease Control Program in 2000. If we see the breeding sites of Aedes aegypti, the vector for dengue, we know it is small artificial collections of water in water flower vase, water pots, wheels, uh, coolers, fridges, and any small artificial collections of clean water. So, dengue is predominantly in urban areas where such water collections are readily available. Now, the control strategy for dengue, it predominantly focuses on anti-larval measures through public awareness and community involvement. The main pillar stone is public awareness and community involvement. Friends, if you remember last year, the Chief Minister of Delhi has initiated a campaign, said every Sunday 10 a.m. 10 minutes. This campaign focused on drying off all the water collected areas or the water filled areas for 10 minutes at 10 a.m. every Sunday. Essentially, it is a public awareness and community involvement strategy to eliminate the breeding places of Aedes aegypti and leading to control of dengue. So, the most important part for dengue control is source reduction. Others are same as discussed already: protection from mosquito bites, early diagnosis and prompt treatment. Now, we'll be discussing about Japanese encephalitis. Now, Japanese encephalitis is caused by Culex mosquito, which is also called nuisance mosquito. It breeds in dirty water, and it is also nuisance mosquito since it creates a noise around our ears. Gun 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 kind of noise that mosquito creates is Culex. Japanese encephalitis virus is primarily zoonotic in nature. Its natural cycle is in pigs only, while man is the accidental host. The virus is neurotropic and primarily affects the central nervous system. The control strategy for Japanese encephalitis is also very similar, that is to care of the patient to prevent the sequelae of the disease. We also have a safe and effective vaccine against Japanese encephalitis. Surveillance activities in the form of sentinel surveillance, including clinical surveillance of suspected cases and studies to identify high risk cases, are done. Epidemiological monitoring of disease and its effective implementation of preventive and control measures are done. So, after dengue, we'll be describing about Kala Azar. Kala Azar is caused by Leishmania donovani and is transmitted to man by the bite of female sandfly. Uh, it is endemic in eastern parts of India, Bihar, Jharkhand, West Bengal, Uttar Pradesh, and the target is to reduce the annual incidence of Kala Azar to less than one case per 10,000 population at block level and PH. The strategies are also the same: early diagnosis and complete treatment. So, early diagnosis, we have rapid diagnostic test kits RK39, they are available, and the drug miltefosine is used for treatment. Interruption of transmission through vector control by insecticide residual spray with synthetic pyrethroids up to 6 feet height from the ground is done twice annually. So, uh, sandfly can maximum jump up to 6 feet of height, and so synthetic pyrethroids are used for indoor residual sprays during the transmission season. The other aspects are behavior change communication, intersectoral convergence, capacity building, monitoring, supervision, and evaluation. We also have rapid diagnostic test kits developed by ICMR available. In addition, single dose treatment with amphotericin B, which is given intravenously in 10 milligram dose, is available and is given to reduce the human reservoir of infection. Lastly, in just one slide, we'll be discussing about chikungunya. As dengue and chikungunya both are caused by the same vector, Aedes. So, control measures for dengue are the same. Similarly, chikungunya, dengue, and urban malaria all have same control measures. The same sentinel surveillance hospitals are involved. All the survey mechanisms are same. However, diagnostic test kits are available separately for chikungunya, separately for dengue, and there are malaria diagnostic test kits are also available. So finally, we have completed the entire session and just a couple of more slides to summarize the entire topic. The six vector-borne diseases are malaria, filaria, dengue, kala azar, Japanese encephalitis, and chikungunya. Anopheles is dangerous or most dangerous vector as it causes malaria, which has led to lakhs and lakhs of deaths, mortality. The other dangerous part is Aedes. Aedes is tiger mosquito. It is more dangerous as it leads to viral disease, and we don't have any particular drug for dengue and chikungunya. Culex nuisance mosquito. It causes filariasis or disfiguring disease. So nuisance mosquito leads to filariasis and Japanese encephalitis, while the non-mosquito vector sandfly causes kala azar. This is the summative slide of control measures for all the programs and all the disease. So disease management, it begins with case detection, early case detection. After detection, we go for complete treatment of case. If treatment is not possible at local level, we have to refer the case. We have to be prepared for epidemic response, and rapid response teams are to be prepared in advance. Then vector control, entomological surveillance, that is surveillance of vector species for insecticide resistance. Then anti-larval measures, which is predominantly in urban areas, anti-adult measures in the form of indoor residual sprays, predominantly in rural areas, supportive interventions in the form of behavior change communication, intersectoral convergence, public-private partnership, operational research, monitoring and evaluation of the. So here we complete the session. If you have any questions, you may post your questions, write your questions in the WhatsApp. Uh, if you have any feedback regarding the today's session, please write it, convey it to me. I will definitely improve upon it in future. I'll be providing you a link after 10 minutes uh, and you can just quickly fill up the question. Thank you for your kind listening, patience. Thank you.